The number is really growing very fast, to our huge pleasure. And I think that we can start. And dear colleagues, dear participants, we are very happy to welcome you to today's webinar that have fueled a lot of interest and excitement. And we received almost 700 registrations from our region and many countries beyond. It speaks for its great relevance. And despite the fact that all professionals agree that monitoring of child development is a crucial step in ensuring that we can provide optimal support, this practice still doesn't live in many countries in our region. That is why today we are focusing on this topic, not to talk about what doesn't work, but to share with you promising practices and give you ideas and encouragement to apply them in your countries. This is our 10th webinar on health systems for early childhood development, and you can see all previous one on the link that my colleagues will paste in the chat. And before we start, let me share with you some basic information on the logistics. And if we can see the next slide, you will see at the bottom of your screen the globe that symbolizes translation. Please click on it to choose one of the translations that we have available today, and you will see Albanian, Croatian, Bosnian, Montenegrin, Serbian, Slovak, Russian, Ukrainian, and Hungarian. And please use the question and answer box or chat box to write your questions and comments during the whole webinar, because we have a lot of interesting presenters that are very keen to share with you their experiences, but we will always be short on time. So please note that our presenters today have kindly agreed to provide their contacts with you in case that you want to connect with them later and learn more. With that, this is also to remind you that Health Systems for Early Childhood Development is a joint initiative and continues to live in that spirit. And I have a pleasure to invite representatives of all partners to share their opening remarks. You will see the agenda quickly on this screen. It is very, very packed, and we will try to give the due time to all the exciting presentations. But starting with the opening remarks, we have Evelina Borisova, Regional Early Childhood Development Advisors in UNICEF Europe and Central Asia Regional Office, Martin Weber, Team Leader from World Health Organization for Europe, and Michaela Ionescu, Program Director from ESA. And Eva, would you like to start?
Of course. Thank you so much, Alex. Good morning, dear colleagues, partners. It's really fantastic to see so many of you together with us. And it's really a privilege on behalf of UNICEF to extend a very warm welcome to each and one of you and to our first webinar of this year under the Health Systems for Early Childhood Development initiatives. For those of you, and I hope many of you who have been with us since the beginning, you know well the journey that we embarked on more than a year ago, a collaborative effort between UNICEF, WHO Europe, and the International Step-by-Step Association, with a joint aim and goal to really transform and strengthen health systems to provide more comprehensive support for the development of the youngest citizens in our countries. Today, our focus is on a topic that has received increasing attention from policymakers and practitioners alike, and it is on the monitoring of young children's development. Welcome to those who are just joining. I'll say just a few words about developmental monitoring because UNICEF is deeply committed to this area of work and excited to be co-host of this webinar. Developmental monitoring is not just an activity. It is a vital conversation that engages professionals and families in understanding and supporting the very unique developmental trajectory of each child. And it really empowers parents to support their children's growth effectively while also enabling early identification of developmental concerns, ultimately ensuring timely support and intervention. In a way, at its core, developmental monitoring is about ensuring that every child receives the best possible chance to reach their full potential. And I know we're committed to this mission jointly, which is why so many of you are here on this webinar today. It is a critical element of every effective early childhood intervention system. And as you would hear in this webinar, it is also a critical element of every effective and progressive primary health service. Let me add one more perspective, and it is the policy one, because developmental monitoring holds significance beyond the individual level. From a policy perspective, universal system of developmental monitoring can help generate rich source of data. And by analyzing this data at a population level, we gain valuable insights into how young children are faring nationally. It helps us understand their needs better and the needs of their families, and can inform the formulation of better public policies that foster an environment where all children can thrive. We're here to talk about health systems when it comes to developmental monitoring, because this is an area where health practitioners with their deep knowledge of child health and development are uniquely positioned to champion developmental monitoring and to make it an indispensable part of primary health services. Their trusted relationships with parents and frequent interactions with young children make them allies in this endeavor, and true, important, committed allies. However, for them to succeed, they require adequate time, supportive policy environment, the right skills, and validated tools. And I think we'll hear about all of these things in the next presentations. Throughout this webinar, we will hear from a few countries, as Alexandra already said, on what works, not what doesn't work, but what works, and how do we organize developmental monitoring in an effective way, and what is the critical role played by the health system in supporting that. We hope very much that by sharing these examples, we can inspire more countries to prioritize developmental monitoring as an integral part of well child visits during the early years of life. And from UNICEF's side, we are already working collaboratively with governments, with our partners, with health professionals and other stakeholders to scale up developmental monitoring. And we stay committed to continue this journey with all of you after this webinar and well beyond. Thank you so much for joining us in this journey and of knowledge sharing and collaboration, and look forward very much to the presentations.
Thanks a lot, Evelina, for your kind words. And Dr. Martin Weber will say hello on behalf of WHO.
Thank you very much, Alex. And thanks very much, Evelina, for setting the stage so well before. Let me just say a few words on behalf of WHO to emphasize again some of the points in developmental monitoring. To see so many participants today speaks by itself. I think it is a topic of huge interest, and I think you will not be disappointed in this session today with the speakers who are going to share experiences and frameworks with you. It has been said already, developmental monitoring is definitely one of the key activities in medical interactions for young children. Assessing children's developments, counseling parents, and if there are concerns, referring children is the key intervention to put young children on their best developmental trajectory. This requires good primary healthcare services where a trusted provider is maintaining the contact with the family and responds to their requests. The provider can be a community nurse, a family doctor, or a pediatrician, depending on your health system. This might also happen in community outreach or in clinics. This again depends on your health system, but you will hear in the examples today where countries believe there is good practice. I just want to emphasize again, community outreach has certainly specific advantages for the interaction as you see the child in his natural environment, and therefore it should be at least part of the primary visit. Developmental monitoring requires functioning referral pathways without too much delay, and we know here the problems come. When concerns are identified and help needs to be provided, you cannot wait for too long, otherwise people lose the trust in the health system. The primary care provider identifies the problem, but somebody else has to diagnose it. And this interaction between the primary and the specialist care with referral upwards, but also referral back to the primary provider is an important area which really has only recently received adequate attention. Health systems are still struggling with this. To help in this endeavor, and that has been part of previous sessions last year, WHO has published the Pocketbook of Primary Care for Children and Adolescents, and this gives an outline of typical developmental monitoring visits along the life course, what to do, what to look for, and what to ask. Countries need to adapt it, but we know that many of the country systems are not optimal for serving these purposes. They are often relying too much on screening, particularly in the eastern part of the European region, as the main approach. Screening without access to useful interventions, and overdoing it, only creating anxiety with parents. We also had, we all know it, COVID-19 as a particularly disruptive period for countries' approaches, where developmental monitoring was often downgraded as not being so essential. And this is creating an enormous backlog in many of the countries. Health systems are still struggling to overcome this, and needless to say, some children have been suffering. With this in mind, countries might review their existing system and compare them with international standards. And all of you have a role to play in this to help creating better systems and implement it. Today's webinar will give us useful examples that has already been said by Evelina, and we have a keynote speech from one of the key authors of the developmental monitoring chapters in the pocket book of primary care. They will share how developmental monitoring is organized and their strengths and weaknesses. It has also been part of a previous session that UNICEF and WHO have developed jointly a framework for early childhood development, which is available on the websites. And there is a tool, an assessment tool there. So this might help you assessing your situation. We are working jointly, the UN agencies, again, on a regional strategy for child and adolescent health, in which developmental monitoring is one of the pillars. So interact with your governments to see this move forward and then make good use of it. This has just been a few observations to set the stage from the WHO perspective, and we are all looking forward to a very fruitful exchange. I welcome you to this. Back to you, Alex.
Thanks a lot, Martin, for these wonderful words of introduction. And I'm passing the microphone to Dr. Mihaela Ionescu from ISTA.
Thank you so much, Alex. And I will be short because I think that already the interest in the content of the webinar is growing, as with the introduction words from Evelina and Martin. On behalf of ISTA and the Health System for Early Child Development, I'm also honored to welcome you. And it has been already said that the first years of life offer immense opportunities for growth and development for all children. While most children follow a typical trajectory of development, there are some who are at risk of developmental difficulties. And for these children, the timely and adequate support in the first years of life can really enhance their development or even alleviate the impact of disabilities. We at ISTA, and that's why we are strongly partnering with UNICEF and WHO, we strongly believe in cross-sectoral cooperation and bringing all professionals and services together to exchange information and practices and learning from each other. And to be able to work together, all sectors should build a shared understanding of what developmental monitoring and approaches in monitoring child development are. They might not use the same tool, but the values and sensitivity for developmental challenges should be the same. Additionally, we also promote the whole family approach, and it has been already mentioned, the crucial role that parents play, and having them engaged as partners and sources of most valuable information and potential to support their children. Thus, across the early childhood services, the universal developmental monitoring should engage parents in conversations about their development, helping them strengthen their understanding and the competencies to promote their child development holistically as part of their daily family routines. Well, this focused conversation, it has been mentioned already in health institutions, but also in early childhood education and care settings. They provide a safe space for parents to share and to discuss concerns they have about the child's development and get direct help for the child or through referrals. Health professionals, instead, they are best positioned to identify those concerns for child development and ensure the access to appropriate support for every child. It's a trustful relationship that has to be protected, and that is only if professionals are well equipped with the right competences to do so. We hope that today's presentation will showcase how developmental monitoring is organized in several countries, and as part of the health routine care services for children. And this will prompt health practitioners and policymakers to integrate more systematically the developmental monitoring in routine practice, along with the more traditional focus on the health, immunization, and nutrition of young children. This way, for all of us, this is the way for all of us to timely identify children at risk of developmental difficulties. Since this is critical to ensure that they have received the support as early as possible, when actually the potential to enhance their development is the highest. Thank you for all of you participating today, and also for all those that have agreed to share their knowledge. I think that this has become a very powerful platform for knowledge sharing, also influencing our thinking and our daily practice. Thank you so much. Alexandra, back to you.
Thank you, Michaela, and your words are very truthful because we do have participants from the whole world. And thanks a lot for your trust and for your excitement. And as we are moving now, we have heard a lot of important concepts about developmental monitoring. So I'm afraid that the next presentation, we'll be repeating some of them. But we have immense pleasure to have Dr. Revan Mustafa with us, developmental pediatrician and a member of the International Developmental Pediatric Association, who is from Istanbul in Turkey and a passionate supporter of developmental monitoring, someone who has helped many countries and professionals across this region to accept the importance and start implementation in practice. He also worked with us on development of the regional report on developmental monitoring that will be released soon to provide guidance to professionals and decision makers on how to operationalize these commitments in practice. Today, we have asked Dr. Revan to share the main concepts and principles that should guide developmental monitoring, as well as to shed light on health system aspects such as human resources, work processes, selection of tools that we have already heard sometimes present the important barriers. So Revan, over to you, and looking forward to hear your presentation.
Thank you very much for introductions, Alexandra. Hello, everyone. So nice to see you. I know some of you, and glad to be introduced to the ones I do not know, but hope I will meet you soon. So let me share my screen. Oh, excuse me, let me share like, okay. Okay, now you should be seeing my screen. Is that the case?
Yes, we can see it. Just waiting for the presenters for the full screen.
Okay, so do you see the like?
No, you can duplicate the screens.
So you do not see the slides, right?
We see the slides, but we see both.
Oh, you see both. Okay.
Now it's perfect. Now it's perfect. Over to you, Revan.
Okay. I will try to share in 25 minutes an approach to address developmental difficulties. We call it developmental monitoring. So let me greet you first of all. So it's really interesting that Zdravo is actually a greeting in many languages, not only one language. And if there are ones whose language is not represented here, let me just do it in English. I'm sorry that I was not aware that you will also be here, but welcome. So this is my outline. First is the basics, the brain development, developmental difficulties, and the approach to address them. And the second part will be about the health systems, what should happen in health systems to make developmental monitoring happen. So I'll start with development. And when we talk about development, it's actually brain development. It's really brain development of children. So here on the left, you see the microscopic images of infant brain, and the number of cells neurons is actually constant, but what changes at an astonishing speed of 1 million connections per second is the synaptogenesis, right? The connections that the cells made. So you can also see these changes if you make a PET scan of an infant brain. You can see that these active areas of yellow and red, they just They become all over the place in the child's brain, and it's because it's developing really, really quickly. So the long debate of is it genes or is it environment, nature versus nurture debate, it's over. Now we know for sure that it's both genes and both the environment that shape the child's development. Children just do not develop in vacuum. They need environment to grow. So this environment is the child's proximate family, mother, father, siblings, and this is a more distal environment. It's the society, it's the community, and in the end, it's the world that is the soil where children develop. So when we look at, so nature and care framework puts it nicely, summarizes it nicely, what a child needs to grow optimally, to develop optimally. And you have all these summarized under this categories of nutrition, health, its security and safety, and its responsive caregiving, which is very important, and opportunities for the child for early learning. So because these last two, the responsive caregiving and opportunities for early learning, it's somehow something soft and it's not something concrete. Let me show you what I mean when I say responsive caregiving and opportunities for early learning. So here you see the interaction between a small baby who is at the hospital and his mother. And let just me show you it. So a really nice moment they are having, right? A dance of interaction between mother and an infant. So they are looking at each other. So the mother is responsive and she has playthings to engage the baby around. So this is what we call a nurturing care. This is what we call responsive caregiving. This is what we call to give the baby opportunities to learn early. So whatever that gets in the way of this, it's called developmental difficulties. So it's any condition that puts a child at the risk of suboptimal development and that causes a child to have a problem, to have a delay, to have a disorder, or to have a disability. There are many, many reasons for that. Here, they are listed in the in the decreasing order. So it's a mix of health-related and psychosocial risks. And you can see that number one is actually whatever gets in the way of nurturing care. It's lack of nurturance, it's lack of responsiveness, lack of stimulation, lack of stability. So you see that the genetical conditions, they are actually far, far down there. There are things that we see more often as reasons for developmental difficulties. So we do not know the true prevalence, to be honest. We know that it is higher than developmental delay disorder or disability by definition. So we know that in USA, 1 out of each 6 children has a disability. That's the result of a study. UNICEF has similar numbers according to a review where the median prevalence of was 18% for children under 10. So developmental difficulties are the most common condition with long-term ill consequences. When we look at the developmental difficulties, it's not something as black and white. So there are children who develop optimally. There are children on this end of the spectrum who have risks but still develop normally. There are children who have risks but are also delayed, and there are children with obvious disability. So it's a spectrum of conditions, right? And when we look at the children, at children with developmental difficulties who will step into your office remember that will be one child out of every 6 children who steps into your office as a practicing physician or nurse or whoever works in the health system. So what you will see is cerebral palsy, it's Down syndrome, it's maybe some chronic diseases that you will notice with your eye. But what you don't see, and it's all below the water, is psychosocial risks, it's autism, it's speech delay, it's cognitive disabilities, it's hearing loss. So a lot of things you cannot see with your eyes. So pediatricians understood this in early 80s, that they cannot just rely on their clinical experience. They could identify only 30%. And think of flipping a coin, it's even higher. You get 50% of getting the right answer. And so in early 90s, we understood that we need to use standardized tools. We arrive at something like 70% of identification. So these tools, developmental screening tools, became widespread in some high-income countries, and even low-middle-income countries adopted some of them. So Denver's developmental screening test is a prototype of such tests. So the initial approach of looking for a problem was like very widespread. It's called screening because screening is looking for a problem and finding a problem. But starting from early 90s, a lot of literature started saying that screening approach is not suitable for child development because you are looking at the child only, and that's not theory. The theory says that you have also look at the environment. The literature was saying that it's not focused on prevention. So you should also be looking at what happens before, between, and after the developmental screening. It's not constructed for partnership, and families are important. We should be partnering with them. And so the end result of a developmental screening is just refer, identify, and refer. But if there are no services, it's just not ethical. And there were problems with the way these tools were constructed. So, for example, excuse me. Okay, so this slide didn't work the way I intended, but let me show you what I mean when I say problems. The problems were that the developmental screening tools were constructed so that they give you a score or they give you a category. So imagine you have a score of 59. So it's generally delayed in most of the tools. So imagine you get that score at 9 months of age. So what do you say to the family based on that score? So for example, if you get another score, what the difference between 65 and 59? So what does that score mean for you, for the family? What do family exactly do at home based on this? So you refer, and do services exist, and can families really assess these services? Will families go for those services? So there were a lot of issues raised up in early 90s. So the developmental monitoring approach, sometimes it's also called surveillance in North America, aims to keep track of and support each child's development. So that this is a definition from the nurturing care framework. And so it's not just looking for a problem. It's not just looking for a delay. It's much more. It's also supporting the way family provides care. It's supporting family to provide that care. It's looking and addressing biopsychosocial risk factors and also helping the family to deal with them. It's educating families on their rights, on linking them to their services, including family-based resources. So it's a partnership with families and informed watching, enjoying child's development on the course of monitoring. So let me just dissect it a little bit, what that means. So in first place, it means acknowledging the importance of the family, which means that professionals treat them as equal partners. They acknowledge them as an expert on their own child. They know the best. They spend 24 hours a day with their child. We pay attention to what family members say, think, and feel. We respect their priorities and we decide everything together. We do not tell them what to do. They know what they want. So we need to come on terms with that. So in second place, it's asking the concerns. So we should be asking and following up on their concerns about child's development. Parents frequently know that something is going wrong. And numerous research has shown that whenever there is a concern, the likelihood of a developmental difficulty is really, really high. It's research 40 years old. It's providing a holistic assessment of development in the domains of language, socio-emotional skills, motor skills, self-help skills. It's using standardized tools at regular intervals and whenever there is a parental concern. So we do this to understand the strengths and difficulties of the child. And we use this information to support the child to get to the next progressive milestone. So it's not just about learning whether the child is delayed or not. It's more than that. So here is, this is a photo of Jamal from Turkmenistan doing developmental monitoring. So this is a family with a child. And this is how it looks like. So it's not just a professional with a pen in hand and just ticking something and raising the suspicions of the parent, oh, what this professional is doing there. So let me share what I mean by helping the child to get to the next milestone. So imagine a child who is sitting without support, but is not yet standing with support. This child might be delayed or might not be delayed. But what's important that the parent leaves your room knowing what she needs to be doing at home to help this child stand with support. Of course, you do a bunch of other things if this child is delayed. But what the parent needs to know for sure is how he proceeds next, what she does next. So it's looking at the nurturing care environment and understanding what the family is already doing and what else can be done. It's understanding who is looking at the child and how others are involved, especially how father is involved. Parental involvement, father involvement is really, really important. So we also need to look at the risk factors and address them. So the risks are all related to the components of nurturing care. So we will already be looking at health-related risks through our medical exam in health systems. But we also need to assess for psychosocial risk factors. I will not just list them. I have already talked about them. The most important one is lack of nurturance and responsiveness. So the end point is that we should arrive at the same level of understanding with the parents. So we should be praising the family for what they are already doing. We should empower them to do more, share the strength and difficulties of the child. We should talk about concerns. We should understand what the caregiver is feeling, how the things are going for the family, address their feelings of guilt, and help understand what they need to be doing next. And we should be checking for the caregiver understanding. If there's not something well understood, we should be just repeating that. So we should be decreasing the number of risks and increase the number of protective factors so that we have an optimal developmental trajectory. And we decrease the number of modifiable risk factors because we know that if the number, you see that ladder, so the more risks there are, the higher is the likelihood of developmental delay. So if you are able at least drop the number of risks by 1 or 2, you lessen the chances of this child getting a developmental delay. And we do this not as a one-time thing, we do it longitudinally. So we are aiming at assessing health and psychosocial risks prenatally, birth, and each visit. We should be looking at this. We should be doing developmental monitoring for children with no risks at least once a year. So here I have indicated the intervals in month. For children with risk but no delay, we should be looking at them closely. And with children with delay, we should be doing this more frequent and maybe also consider EI services, early intervention services. So let me jump into the second part to talk about how to make this happen. So the first question is, who should be doing that? So development is for healthcare. Development is a job of healthcare because it is not something separate from health. It's a part of health. So because infrastructure there is infrastructure that can assess all children. In healthcare have reach all young children and they have regular contacts with healthcare. Typical healthcare employs professionals who possess training which is conducive to developmental monitoring, and physicians, nurses, and midwives are really trusted in the communities. So in our region, in Europe and Central Asia region, there is good infrastructure. It is accessible. There is high coverage with basic services. There are physicians and there are nurses. And the number of provider-child contacts is around 14 under 3 years of age. And many countries have a home visiting system. So a whole bunch of opportunities to do that actually. So another important point that I think is really important, I really want to stress this. This is to say that developmental monitoring should be for all children. It's not only for some children who have some red flags. So if we do not monitor every child, some will go unnoticed, systematically go unnoticed, and will get identified very, very late. So let me talk about training a bit. So when I say training should really teach child development, that means that there is training, but it's not really teaching child development at the moment. We have curricula, but this curricula narrowly focus on skills of limited clinical utility. So we teach only milestones, we teach only red flags, we teach only red checklists. That's not enough. And I think this is because generally there's such a mindset that, okay, medicine is for nurses, medicine is for physicians, and development, it's just for someone else who is working in some specialized facilities. No, child development is for health. Child development is for everyone who has a contact with a child and a family. So I will not just read this what training programs should really be teaching. This is actually what developmental monitoring is. So we should teach this to everyone. So training programs should teach this to everyone involved, because not speaking the same language will disrupt the continuity of care. So when nurse hands over to physician, when physician is handing over to the other physician, if they do not speak the same language, there will be disruptions. So when physician sends the child to the other center, the referrals become ineffective. So let me share an example. So early childhood development training program in Turkey trained 146 healthcare providers 20 years ago. So they were really proficient at the beginning, but when they were interviewed a year later, they said that they just did not practice their skills because they were discouraged from the disruptions. They were identifying, sending children to centers, and pediatricians there were saying, oh, your child is okay. Why did you come? So the parents were really confused. They returned and just asked those professionals, why did you send me? So they were discouraged. That's why this point is really important. So the last thing I want to say about training is that it's a waste of effort if you do not couple with efforts to give time, reimbursement, tools, mandate for developmental monitoring. So let me talk about allocation of resources. So time is the most important and a traditional barrier. What we ask for children, what we ask for them is that health systems provide uninterrupted 30 minutes per child at least 4 times during the first 3 years for all children, not some, for all. So how do we create this time? So it's a lot, right? I mean, when you talk to policymakers, they will say this is a lot. Here are some places where you can release time. So we could make use of routine child healthcare contacts and home visits. We could release time from redundant well child care visits. So imagine I said that the average is 14, but there are countries who have 42 visits, scheduled visits in first 3 years of life. So that's a lot. And I think they are mostly on paper. They do not happen. So why not use it for developmental monitoring? So we can optimize workload, assign dedicated staff. So there are performance-based health systems. We should introduce reimbursement for developmental monitoring, because if you do not pay for it, it will not be prioritized. So we should be passing policy that values ECD, that prioritizes quality over quantity and commits to creating resources, and regards ECD as a long-term investment and not some like of short-term financial enterprise. So we should be aligning legal documents with theory and practice and evidence. So we should be mandating for developmental monitoring, and if it's not mandated, it will not be prioritized. I have already said that. So many national child health care supervision protocols, baby protocols, I would say, they do not go beyond saying assess child psychomotor development. So I have looked at many. So there are exemplary ones. So here are the screenshots from 2 of these Turkish guidelines and the primary healthcare pocketbook for children and adolescents by WHO. You can refer to that. So the last thing I want to talk about is tools. So what cool tools we should be using for developmental monitoring? So the qualities should be brief. They should cover the first 3 years of life. They should cover language, socio-emotional, motor, and self-help domains. They should be evidence-based. That means that they should be standardized and validated. So there are many tools in the region which are not standardized and not validated. Manfred Prettis has given a lot of space in his report to these tools because he has looked at these. So do not use tools which are not standardized and not validated. And these tools should be easy to train in, and they should be culturally adaptable. So let me just show you the tools that were shortlisted by independent researchers for programmatic use. So they were shortlisted based on a bunch of criteria. These are validity, reliability, cultural adaptability, accessibility, training, administration time, geographical uptake, it should be, clinical relevance, and utility. So you see that 3 tools stand out prominently here. So let me read out them for you. It's PEDS, Parents Evaluation of Developmental Status. It's a Guide for Monitoring Child Development, and its Ages and Stages questionnaire. Given the shortage of time, I will stop here, but if you have additional questions about this, we can expand on depending on your questions. So thank you for being here, and we'll be glad to connect you with this mail address. Thank you.
Thanks a lot, Revan, for the amazing presentation, still managing to cover a lot in a relatively short period of time and give the main principles of developmental monitoring, talk about what are developmental difficulties. We struggle very often to explain that we are looking for the broader range of difficulties and not only disabilities. So your presentation really provided excellent overview of the principles, as well as the considerations at the primary healthcare system level, what should be in the hands of the practitioners if they are to implement it. I'm trying to see if we have and get from our colleagues that are monitoring the chat, if we have urging questions for Revan to respond at this point, because in the next part, we have 4 presenters that will present 4 different screening tools and processes through which developmental monitoring is implemented in their countries. So you will hear more about very practical examples. Vera and Zorica, I mean, there is one question, Devan, in which a colleague is asking, are there any manuals or guides that would ensure that we speak the same language or that we teach the same language across the different levels and professionals within the health system? So you have shared two, the Turkish guide and the pocketbook for primary healthcare. Is there anything that comes to mind? And maybe you can announce also the release of the report, in which as well you have given sufficient space to describing the key principles of the training and the tools.
I think so the training. If we are looking at an exemplary guideline, I think WHO pocketbook has summarized. We really struggled a lot to keep it short and summarize there. But of course, it's a job aid. It's not something that you can take and just grasp all of it. You will have the principles and you will have the main points there. So it's really up to the curricula that should be teaching that, and the curricula should become, I would say, teach a coherent set of competencies, because what curricula currently teach is that they teach only some skills, but not as a whole package. So and to say a few words about the report that we are preparing now. The report is about I would say, as a manual to making developmental monitoring happen, what we should pay attention to. So it's based on a lot of things. It's based on scientific evidence. It's based on research, and it also has a flavor of our collective experience of interacting with health systems. So it's underway, and I hope it will be made available to you soon.
Thanks a lot, Revan. And with that, we'll move into the next part of the webinar, but all the presenters are there and they can respond to your questions. And they have also, I'm repeating, have agreed to provide their contact so you can exchange with them bilaterally. I think that is the rare opportunity and very, very generous from them. So we are moving to the country's experience section, and I hope that this part will really help to add color to the concepts that are presented by Revan, as we will hear how these concepts are operationalized in reality of several countries. So you will hear, you might remember from the agenda that we will hear from Scotland on the uses of AGIS and STAGIS instrument. Then we will hear from Portugal on the uses of Mary Sheridan's milestone as a part of the primary healthcare and information system. We will hear from Azerbaijan on the experience of using guide for monitoring child development, and finally from Slovakia on the use of the locally developed tool that is strongly enforced by the Pediatric Association and pediatricians in Slovakia. Without further ado, let us start with Scotland. And I have a pleasure to introduce two great speakers from the Public Health Scotland, Suzanne Branton, that is a consultant, and Linda Fenton, that is Senior Data Analyst at Public Health Scotland. And two of them will share with us how is developmental monitoring integrated in home visiting services in Scotland, where home visiting nurses use AGIS and STAGIS tool. The data they collect are analyzed and influences public policy making. Over to you.
Thank you very much. Good morning, everyone. Yes, I'm Linda Fenton from Public Health Scotland. Really delighted to be here and great to have the chance to share some of our experiences from Scotland with you. Let me just share my screen. I hope that's coming through okay now. We have maybe 15 or so slides just to give you a flavour of how the health visiting service is organised in Scotland to provide support for families of young children, how the AGIS and STAGIS questionnaire is used within developmental assessment here, and then how we gather that data nationally to provide monitoring information at population level and some of our recent results from that. We're both members of staff at Public Health Scotland, so we're the national public health agency in Scotland, and our responsibility, I guess, within this pathway is largely around about that national data and intelligence and reporting, but the whole health visiting service is embedded within our wider NHS service. So yeah, we're speaking to you from Scotland, up in the dark green there, tucked away in the corner, and actually I'm speaking to you from a relatively small island off the west coast of Scotland, so great to be speaking to such a wide audience from here. As part of the UK, we have a national health service covering the whole population, providing universal health care that's free at the point of delivery, funded through general taxation. But in Scotland, that's a kind of devolved power at Scottish level, so we have our own structures and organisation around about health services in Scotland. And for those who don't know us, we have around about 5.5 million people, about a fifth of the population are children, and a child population increasing by about 45,000 per year. And just on the kind of administrative side, the map on the right just shows how Scotland is divided up into 14 health board areas. And these are the sort of responsible units at which healthcare is delivered and oversee the delivery of health services. And that just becomes relevant when we're thinking about getting consistency and comparability in practice for developmental monitoring. So we have what's called a universal health visiting pathway. And for those who are not familiar with the staff group of health visitors, these staff are already qualified nurses or midwives who undertake an additional master's level qualification in specialist community public health nursing and are then able to operate as health visiting professionals. It's a long-standing sort of professional group. It had its origins in Victorian philanthropy and has been part of the NHS as a service since the 1970s. But the pathway that I'm talking to you about today was revised substantially in Scotland in 2015, like I say, to bring a degree of consistency in the support that was being offered by health visitors and how assessments have undertaken. We do have, as part of that pathway, 11 home visits and antenatal home visits across the first 5 years of life. As you can see there, the green box are those visits that are concentrated in the first year of life, particularly in the early weeks, and then a visit at just over 1 year, a visit at roughly 2.5 years, and then a visit at 4 to 5 years. This is the standard universal pathway that's offered to all children, and then there's the opportunity for that to be more intensive where additional supports are identified. And just to be clear, this isn't just about developmental monitoring. This is a sort of comprehensive child and family support service through which a whole range of primary care and preventive services are offered to children, including immunisations, family support, support for postnatal depression. All these things are sort of identified and partly supported by the health visitor, and then there's the opportunity for them to refer wider in the health and social care system. At our we collect national data from these interactions at 5 points. So from the new baby visit, from the visit at 6 to 8 weeks, and from the older age group visits, we gather information nationally to allow us to undertake reporting. And at the 3 older visits is where the ages and stages questionnaire has been implemented to support developmental assessment. So just to give a brief introduction to the ages and stages questionnaire, for those who aren't familiar with it, there are 30 questions covering 5 developmental domains, as listed there. And there's also an overall section in which parents can report any general concerns they have or any specific medical problems that might have been identified elsewhere to bring that into the assessment. And this is just a sample of what it looks like. It's a questionnaire that's designed to be completed by the parents. And there are a whole range of questions. To give an example, I think this is from the 48-month questionnaire. The gross motor question is, does your child climb the rungs of a ladder of a slide and slide down without help? And for each question, there's 3 responses that a parent can give: yes, sometimes, or not yet. And like I say, it's designed to be completed by parents. In terms of how that's done within our process, I think it varies from health board to health board, but often the questionnaire might be sent out in advance of the health visitor home visit, when the arrangements are made for that visit, so that the parents can complete it in the 1 or 2 weeks before the health visitor then attends the home, and then there's an opportunity for the health visitor to review it alongside the parent at the time of the home visit, when the health visitor can also make some observations of the child and the environment. In terms of the outcome of the ASQ, and how it's scored and the thresholds that are used, there are 21 different versions of the questionnaire to be age appropriate for each developmental stage. This has been important for us, as my colleague Suzanne will point out. Knowing the version number is important. Each domain is scored quite simply. Out of 60 for those responses, you get a 10 for a yes, 5 for a sometimes, and a 0 for a not yet. And then that gives you an overall score, and then that's compared against a threshold to identify whether the child appears to be on schedule for that domain, that they should be monitored because they're close to the threshold, or that there's a clear indication that there's a further assessment required because the score is relatively low for that domain. And those threshold values were developed in the original development of the tool, and they vary by each domain and questionnaire version. There's not just a blank threshold. And just to give a view of how that sits within the overall developmental assessment, there were a wide range of tools used prior to 2015, and part of the sort of refresh of the pathway was to bring in ASQ to be more consistently used in all areas. But there are additional tools that health visitors can opt to use on top of the ASQ in some circumstances if they think a child has a particular area of concern or risk, and some of those have already been mentioned this morning. The PEDS, there's an additional module to ASQ, which is around about social and emotional development, and the strength and difficulties questionnaire. And actually it's the health visitor professional who uses this whole range of information, their own observations of the child and the family, the scores from the ASQ, and any other additional tools to reach their overall assessment of development. And this is recorded, like I say, at this national data point on a standardized form. So this is the form that they fill in, not for you to be able to see the detail, but it has a range of demographic information and other outcomes. And they also record information against 3 other developmental domains that aren't covered by ASQ3, emotional, behavioural, vision and hearing. And they record their health visitor outcome across these areas, that there's no concerns, that there's newly suspected concerns, although there was a previously known concern in a standard box here. And that's what comes into us nationally to be able to understand trends and patterns in developmental outcomes. At an individual level, there are a range of actions available following the health visitor assessment. They might provide some additional support themselves through the health visitor or the wider health visiting team. They might signpost people to additional local services, playgroups, support, library, or then there's the options to refer immediately to specific additional therapy, such as speech and language therapy, or for further assessment, for example, by either a general primary care practitioner or a community paediatrician who specialised in the assessment. If there was evident developmental delay, would be the usual route. And then they continue to follow up with the family following that referral. I'm just going to hand over to my colleague Suzanne to talk you through a little bit about population level data that we have and how we gather that information and report on it at population level.
Thank you, Linda, and good morning, everyone. Lovely to connect with you all today. So as Linda said, we collect this national data on child health reviews, so mainly paper-based forms, and the health visitor fills in these forms with the parents and then submits that to their health board, and then these are entered onto our national information system, which is called Child Health Surveillance Programme Preschool. The data is then extracted and collated by our team here in Public Health Scotland. We've got 2 annual publications that report on this data. So coverage, so looking at how many children actually have the review, and on early childhood development. And that looks at data from the 13 to 15 month, 27 to 30 month, and 4 to 5 year review. And in our early child development publication, we have a kind of headline measure, which looks at the percentage of children with a concern in any developmental domain. And we break that down by various factors, including sex, socioeconomic deprivation, which is based on the Scottish Index of Multiple Deprivation, by ethnicity, language, and whether the child is looked after and accommodated. And we also have a quarterly dashboard, which we just published for the first time in January, actually, and that reports on early childhood development and also reports on infant feeding as well. And the next slide. So this looks at the coverage of the child health reviews. So the 27 to 30 month review is our most long-standing child health review, and it's been in place since 2013. And we usually have close to 90% of children having that review. The 13 to 15 month review has been in place since 2017, and it's now been implemented across all areas. Again, around 90% of children have that review as well. The 4 to 5 year review was also introduced from 2017. However, there's been a slower and more varied implementation of that one, but up to 80% of children have the 4 to 5 year review. And the next slide, this looks at our kind of headline measure, which is the percentage of children with a concern in any of those 8 developmental domains that we were looking at. And this looks at whether they've got a new or a previously identified concern at each review. And as you can see from this, in the COVID period, we did see an increase in developmental concerns at all of these. So in 21-22, 12% of children had a concern at the 13 to 15 month review, 18% had a concern at the 27 to 30 month review, and 15% had a concern at the 4 to 5 year review. And this is the inequalities that we are seeing in developmental concerns. So as you can see, it's quite striking. When we look at the pattern by deprivation, then 26% of children in our most deprived fifth of our population had a developmental concern identified, compared to just 11% in the least deprived. When we look at boys and girls, 23% of boys had a developmental concern at 27 to 30 months, compared with 13% of girls. The pattern by ethnicity, 26% of those of Black, Caribbean or African origin had a developmental concern, ranging down to 13% from the white other category. We also look at whether the child was looked after and accommodated, so kind of in the care of the state. And 38% of children who were looked after and accommodated had a developmental concern, compared with 18% of those who were not looked after. And we also look at language, so whether English was the main language or not. So not too much of a difference there, but 18% of those where English was the main language had a developmental concern, compared with 19% where English was not the main language in their household. And we have a few reporting challenges, as Linda alluded to earlier. So our current IT system collects ASQ3 scores. We've been collecting these for a while. Unfortunately, though, it doesn't allow for the capture of the ASQ3 version number. So we hope this would be simple to add in, but unfortunately, this has not been the case and has been quite challenging. So unfortunately, at the moment, we can't report accurately against the thresholds. And as Linda mentioned as well, as there are so many different versions of the ASQ, basically, yes, we can't report accurately against those thresholds just now. So we do hope that we are having a new system implemented in early 2025. So hopefully over the next few years, we will be able to accurately report against the thresholds, which will bring about some interesting data. And the reporting of the overall health visitor assessment of concerns is helpful, but it's also partly subjective. Therefore, there are some variation in the areas, between health board areas and over time. And just to summarise, so we have 11 home visits in the Universal Health Visiting Pathway that was established in 2015. We do use ASQ3 to support developmental assessment at the 3 points, the 13 to 15, 27 to 30, and 4 to 5 year reviews. We have a range of interventions that are available at individual level. The information on the health visitor assessment of development is collated nationally and presented in our annual reporting and in our quarterly dashboard. We have seen a recent increase in the percentage of children with concerns about their development. And as we've just looked at, there are substantial inequalities in development in Scotland. And just to finish off, these are some links. So the first link there will take you to our publications on early childhood development, and also to our new dashboard, Health in the Early Years in Scotland. So if anyone wants to have a look at any of those. Also to the health visiting pathway in Scotland, you can find out more about that, and also a link to the Ages and Stages questionnaire. So thank you very much, and if anyone has any questions, then please don't hesitate to contact us on our email address there. Thank you.
Thank you a lot, both Susan and Linda, for the great presentation. It is really so amazing and encouraging to see a well-functioning system in which all steps of the process are well connected, from the monitoring to the reporting. And we will open for questions after the next presentation. I see very, vivid discussion in the chat. Please continue posting your questions while we move to another successful story that comes from Portugal. And we have a pleasure of having Dr. Barbara Menezes from the Director General of Health, and within it, Director of Disease Prevention and Health Promotion in Division of Healthy Lifestyle, Division of Infant, Youth, Reproductive and Sexual Health from Portugal. And her story will be very, very interesting because Portugal has fully integrated developmental monitoring into the practice of primary healthcare level. And Barbara will share with us how they use Mary Sheridan's based milestones within routine developmental monitoring and how is it linked with the health information system. Over to you, Barbara.
Hello. Hello, everybody. I'm very pleasant to share with you our experience, and I try to share my presentation. Okay.
Thank you.
You can see now?
It is coming. Yes, you can just turn to presenters mode and we see your slides.
Okay. Can you see now?
We see well.
Okay. Hello. So we have a technical standard from the General Director of Health by the program from health to the child health, and this program doing the surveillance in child and youth health interventions are carried out to achieve a wide range of objectives with a view to continue obtaining health gains in this population. Evaluate growth and development are recorded the data obtained on the appropriate media, namely in the site.
Barbara, I'm very sorry to interrupt you. Could you try speak louder? I think that we have some volume issues. Thank you.
Now you understand we have a national health system, and we have a national health program to child and youth health. You understand that? And so in the appointment with child, we must have to evaluate the development and record the data obtained. We have 17 surveillance consultations, in 6 in the first year of life. In the second year, we have 2, and after then we have the 3 years, 4 years old, 5 years in global health check, and at 6, 7 years old, the end of the first year of schooling, to see how the child is adapted to the school. We have 8 years old, 10 years old, 12, 13 years old, and once in the 15, 18 years old. And how Dr. Riven says, previous studies have shown that the technical most frequently used in health centers to assess development is informal clinical assessment, and that few professionals use standardized screening tests in child health surveillance consultants. This isolated clinical assessment detects less than 30% of children with develop problems. In contrast, the standardized screening instruments have sensitivity and specificity between 70 and 19% in identifying this situation. Is knowledge and application of this simple test by health professionals, namely Mary Sheridan Developmental Assessment Scale, widely used for several decades, which is currently part of the computer programs used in health centers in Portugal, could allow for better knowledge of the typical development parameters of the development and its birth limits. You use the Mary Sheridan scale in all the health centers in Portugal. The test can therefore serve as a reference standard of typical development, helps to focus attention on this area of child health, and also motivate and encourage parents to raise questions and participate in promoting the development of their children. Because, how my colleague said, the family is part of the evaluation. We must to know and to speak a lot of with the parents to understand what happened with the child development. The test covers periods of time in which modifications and acquisitions are more numerous and faster. There are, however, large variations with regards to the speed of obtaining new skills and completing the different stages of development. The psychomotor development disorders are all usually diagnosed by research trials due to the existence of risk factors. I like to say that we have also in all the consultation department a risk assessment of risk factors and protect factors for the child, for the parents, and for the context, the social context. And it's very good to understand if this child have more risk factors than protect factors. And so we must have a different intervention with the parents and with the child if they have a lot of risk factors. I think it's very important to know that and to do that. A suspicion of any problem of the part of parents, family members, or teacher, all the times we must hear and we must understand what is the parent concern. Clinical observation in periodic of opportunistic examination in the context of health surveillance, and in primary health care, an assessment of child development can be carried out effectively without losing simplicity of input procedures. In this context, motivated and experienced health professional will be able to adequately assess a child's development through critical observation from the moment they enter the consultation room until they leave, and very practically during the conversation with their parents, caregivers, or caregivers. At this stage of the consultation, observing the child on their parent's lap or playing while they are not the target of attention and constantly feel more comfortable, allow the professional to draw important and generally relieve conclusions regarding the development of the child. It is very useful to observe her without realizing it, her intention, the type of manipulation she used, her mimicry, cry, etc. And have, for example, one or more toys that she can have immediately access to. This is the list of material to apply in the scale, the Mary Sheridan scale. It's very simple to have it in all the health centers. It's appendix more small, pompan type, with trees attached, spinning wheel, small spinning wheel, similar to a baby toy. Dimension to have colors yellow, red, green, and blue. Pins or clips, small pins for insertion into toy board. Spoon, fork, and hairbrush, small dimension, diameter 5-16 centimeters. And a panel with 10 colors, match card, dark blue, orange, purple. You can. So here you have our system in all the health centers. Is our digital system, and you can see here you have a Mary Sheridan. You click there. We do the the evaluation in 4-6, then the consultation for 6 weeks, 3 months, 6 months.
Barbara, could you
9
try?
months.
I can't see your slide. The next,
Yes.
yeah, now it is here. Now it is here. Thank you.
Oh, sorry. This is what we see in the computer, okay, in the system. We have it's more like a guideline. It's very useful for the nurse or for the doctor, because these consultations are do for the nurse or for the doctor, the general practitioner. And we have one at 4-6 weeks, 3 months, 6 months, 9 months, 12 months, 18 months, 2 years, 3 years old, 4 years old, and 5 years old. And you click, and you have what you must watch. It's behavior and social adaptation, vision and fine motricity, posture and global motricity, hearing and language. This is more easy for us, for the professional, to have these guidelines to remember if the nurse or the doctor have see all the diet. And we have too the alarm signal. If we have a doubt in some areas, we can see if there is a signal alarm for this, for our doubt. Okay, you have 1 month, 3 months or there is more like a guideline, and you can see the new registration, but you can see also the story about these children. And if you don't remind what happened at 3 months, you can see what happened at 3 months and 6 months and 9 months. And so we have the eligibility criteria for early intervention. Even we can see if they have eligibility criteria to referral for early intervention, because it's possible to do that in our system. How I think is Dr. Evans said, the more important thing is to say to the parents what they can do if we have a doubt of this one in the system. We can see what said to the parents of concerning to the parents do with the child. I'm sorry, it's in Portuguese, but what we said is how to play with the child, how to speak with the child, how to put the child in the day, and how can we stimulate the development of promoting activities to promote the child development. And if you need to refer to the early intervention teams, we have here the form, and we can do in the system to do that. And it's what we do in Portugal, and it's what I like to share with you is our experience in the health centers for all the children, because we have a national health system too, and all the children can access to this consultation and to this program. Thank you.
Thanks a lot, Barbara, for the great presentation, and I hope that colleagues could hear and can go back to the presentation to see, because it is fully integrated and a regular practice of every general practitioner and the pediatrician at the primary healthcare level, fully integrated with the health information system as well. We have little time and still 2 presentations, and we have a number of questions that have come to the side. So I would suggest that we continue with Azerbaijan, and we ask kindly, because we have questions for Linda and Susan on the ASQ, to respond to the questions in the Q&A so that all the participants can see them. Well, I would invite Dr. Tarana from Azerbaijan, who can share with us who is pediatrician, neurologist, who is the trainer for Guide for Monitoring Child Development and works in Children's Rehabilitation Center in Baku, who will talk about the use of Guide for Monitoring Child Development, its adaptation and integration in the primary healthcare in Azerbaijan. Please type your questions in the chat. I would ask Dr. Tarana to share the presentation and start. And I would try to ask her to keep to the 10 minutes so that we finish maybe 15 minutes later, and that all participants can stay. Just to remind everyone that all the presentations will be shared with you, as well as the recording of this webinar. And please type all your questions and we will try to respond immediately. Over to you, Tarana.
Thank you, Alexandra. And my presentation about Guide for Monitoring Child Development and its adaptation and integration in the primary health care in Azerbaijan. And at the beginning, I would like to say a few words about primary healthcare services in our country, which are for children aged 0 to 18 years, are provided by pediatric polyclinics. They are designed and based on a district principle. Each has pediatricians and our specialists. One pediatrician is responsible for approximately 80-100 children aged 0 to 3 years, and pediatricians and patronage nurses do home visits to their patients as a part of their mandatory work. Since 2014, at the initiative of UNICEF Azerbaijan, the implementation of the standardized tool into the primary healthcare service for monitoring early child development has begun. At the International Guide for Monitoring Child Development, GMCD, was chosen such a tool. In Azerbaijan, we call it IDIR as abbreviation GMCD. Guide for Monitoring Child Development, originally developed in Ankara University by Professor Dem and her team for over 20 years areas of research, and it is a comprehensive package that comprises 3 components: monitoring, supporting early childhood development, and early intervention. It is based on bioecological theory, family-centered care, and strengths-based philosophy. GMCD uses an open-ended interview technique for monitoring and supporting child development, early identification of developmental risks and delays, and early intervention for children 0 to 14 months. Open-ended questions enable the healthcare professionals to build rapport with the child's caregiver and address challenges such as low literacy, limited knowledge of child development, and any stigma related to developmental disabilities. I would like to give some examples of open-ended questions from the GMCD. Here is, how does she let you know when she wants something? Or, I'd like to learn about her play. Can you give me examples of how she plays? And as you see, the questions are very simple and understandable. And using such questions, we can assess 7 functional domains: expressive and receptive language, gross and fine motor skills, relating, play, and self-help, and also the child's environment and psychosocial risks. And this interview takes about 10 to 12 minutes. GMCD doesn't provide a score or categorization. It has a unique format that allows the user to view the developmentally progressive functional milestones in each of its 7 domains. And here is how GMCD looks. Here you see milestones. Here is 10 open-ended questions relating to monitoring and supporting development. Here is the age range there, children attain milestones, and it's for extra support. And as I said, it is a comprehensive package, and the monitoring only the first part of the package, and it flows seamlessly into the support component using information on where the child and family are and what should be supported. And the supporting component enables the healthcare professionals to assess biopsychosocial risk factors and strengths, and share findings with caregivers and plan individual recommendations for a child. The supporting component, here as you see on the screen, the supporting component includes suggestions to caregivers, how support development in the areas of motor and social emotional development, communication, and play. And also, as a part of supporting component, there is a book, I learned with you, and it delivers GMCD supported PCT component messages with poems and photos, and here you see page from this book. GMCD has been standardized and validated in research conducted in 4 diverse countries, and here you see a research team, and it is applicable internationally without the need for standardization and validation. It is one of few instruments that has adequate psychometric and feasibility criteria to be used in low-income countries, and it is free of charge, but users need to complete their training. And also, there is a GMCD electronic application that will help with data collection and analysis. And it is currently being tested in practice in Turkmenistan. And I hope we learn about the results of testing in one of the upcoming webinars. Integration Azerbaijan primary healthcare system started in 2015. Ankara University team, with the support of the Ministry of Health and UNICEF Azerbaijan, conducted several international training courses in Baku and enabled the training for 7 Azerbaijani GMCD trainers. And our national trainers trained primary healthcare providers by GMCD in early detection and intervention of developmental difficulties. And they started using GMCD in their own polyclinics for the children. And since 2015, the GMCD training package has been incorporated into the curriculum of Azerbaijan State Advanced Training Institute for Doctors. And this training package includes prevention, early identification, interpretation of findings with caregivers, and individualized intervention plan. And I'd like to mention that all practice physicians have to get a course in the above mentioned institute for 20 years. Since 2019, within the partnership between UNICEF, the State Agency of Mandatory Health Insurance, and the Management Union of Medical Territorial Units, with the financial support of the European Union, a new strengthening pattern service program has been launched in Jan. And as part of this program, pediatricians and patronage nurses from 9 pilot districts were trained in GPC. And they started using it during home visits to monitor early child development and early identification of developmental difficulties. And in 2024, it is planned to continue training of all patronage nurses. And to date, about 2,000 specialists, including pediatricians, child neurologists, child psychiatrists, psychologists, and other have been trained to use GMCT, along with around 400 patronage nurses. What are facilitators and barriers in the integration of GMCT in the primary healthcare system? Facilitators it is applicable, feasible, free of charge, comprehensive tool. We have already tested training package, existing system, facilities, professionals, national GMCT trainers, integration in pre-service curriculum, and very important UNICEF support. But we have also barriers. Not all trained healthcare professionals use GMCT due to lack of time, due to absence of an automatic use of of a standardized tool for monitoring child development, and GMCT has not been approved as a single tool for monitoring child development in the primary healthcare system. And at the end, I'd like to share our future goals. We hope training of all primary healthcare providers and the integration of GMCT training package in the medical college curriculum of advanced training course for nurses, implementation of the GMCT output data collection, and investigating the effectiveness, sustainability, advancement, and dissemination of GMCT in the primary healthcare in Azerbaijan. That's all what I would like to say. Thank you very much. And enjoy to monitor child development.
Thanks a lot, Tarana, and thanks for making it really very condensed and still sharing the richness of information and experience from Azerbaijan. It is really commendable, and warm congratulations to you and the whole team behind who have managed to make it really a reality. And I hope that many countries listening on the call as well will contact you directly for the exchange of practice and advice on how to move forward, because changes are possible. Thanks a lot. And we have one more speaker from Slovakia, and another very exciting example where Dr. Olga Matuskova, developmental specialist at Neonatal Intensive Care Unit at the National Institute of Children's Diseases in Slovakia, will share experiences of the online platform with developmental milestones where parents and professionals start their collaboration around child developmental monitoring. We will share the slides for Olga, if she can put the camera on, and we can start. And please add your questions to the chat. We will try to respond to everything that remains open at the end of the webinar. Olga, can you hear us?
Áno, ďakujem za slovo. Srdečne
Yes, thank you for the floor. Greetings to all from Slovakia. In the following 8 slides, I would like to walk you through and introduce the method to you that has originated for the needs of preventative medical examinations in our country. Next slide, please. The developmental examinations are part of the preventative medical examinations of every child. Every child up to 3 years has a statutory entitlement to those examinations paid by public health insurance. In 2019, the Ministry of Health has published a standardized procedure, and those 10 individual regular child visits by the primary pediatrician are linked to continuous monitoring of early childhood development in cooperation with parents. And parental questionnaires got into preventative practice, but also the basic rules of the follow-up preventative measures that directly relate to the assessment of these parental questionnaires. Next slide, please. One moment, please. Just very briefly about this method that links those 10 individual medical checkups, and it's one of the source of data for the pediatrician when they assess the child development. It's a universal standardized method for those 10 preventative checkups with standards and documentation. What's important to report of treatments in those developmental screenings. It's a set of 10 short age-specific questionnaires filled in by the parents, and one record sheet to be completed by the medical doctor. We have paper-based versions and electronic version, and psychometric features were approved. However, standardization was done with or in cooperation with pediatricians from all over Slovakia. There is no need for any special training for this method, and there is an administration manual which is a part of the standardized procedure. It's publicly available at the Ministry of Health website. Next slide, please. This is an example of the questionnaires. On the left, it's the online version where the parents click for answers, yes, my child is doing this, or not yet. On the right, there's the paper version for the parent where they tick their answers. The questionnaire items concern the developmental milestones in motor skills, communication, adaptive behavior. And we also have items that include possible quality deviations in the child's behavior, specific behavior. And there is also the area of parental concern. The items are based on observation of developmental function in small children in normal household situations, and in selecting those items, stress was based on age appropriateness or skills which are age appropriate and predictive skills that could be indicative of further development. By the age of 3, the parent completes 10 questionnaires. There is also the education function for the parent, and what follows is an interview with a pediatrician. We assume that there can be more shared responsibility of the parent for the assessment of developmental function and the needs of increased care if necessary. What is very important, we have to mention that the questionnaires are filled in outside of the medical doctor's office before the preventative checkup. It takes 10 minutes. Parents have the opportunity to do it either at home, online, and I will show it later. And in the online version, The online version also includes videos for better comprehensibility, and this was done in cooperation with UNICEF. Next slide, please. I would like to ask for the next slide. Thank you. This is an example how the record sheet for the pediatrician looks like. Every monitored child has one record sheet, which is included in the health documents of the child. The first record is done in the first line. At the second preventative checkup, 4 weeks of age. The last record, the age of 3 or 40 months, with the 11th preventative checkup, and the doctor or the primary healthcare provider enters just the score that is obtained from the questionnaire that was completed by the parent in a very simple way. With the online version, it's the sum which is filled in automatically, and the same figure is also indicated in the color criteria score. Over those 10 preventative checkups, we get a profile of the score, but also of strengths, a strong and weak functional domains of the child, which is the documentation for the pediatrician to monitor developmental function. I also stress that based on the outcome of this screening, we cannot say that a child is delayed. The outcome is not a diagnosis. It's a comparison of the parents' answers about developmental function of the child with the population standard and indicates the need for further assessment, maybe by direct examination or by referrals or another medical examination. Next slide, please. On this slide, there is information about the website, a virtual center, the health of the child, where all these online questionnaires for parents are found. Its use is very simple. The parent includes the date of birth. The system recalculates the corrected age and offers parents age-specific questionnaire, SPMV, where the score from this basic method, SPMV, is positive at a specific age. The system will also offer 2 targeted screening STECOS for language difficulties and MCHAT screening for autism spectrum disorders. When those questionnaires are filled in, the parent picks from the list of registered pediatricians. They pick their own pediatrician, and by clicking, they send this questionnaire to their pediatrician's email. Every questionnaire is stored in a database, and the parent expresses their consent with this by clicking their personal data processing consent. On the website, in addition to those online questionnaires, there is also basic information on developmental functions and about education on care supporting development, how to create optimum conditions for the overall early childhood development. The access is public. There is no need for registration. Only pediatricians do register. What I would like to inform about is that in terms of cooperation with UNICEF, currently there is a start of the pilot for the new questionnaire for parents, which is intended for those children that were already identified by the pediatrician that they need additional care. This is a new code set, and it's a selection of codes from the classification ICF, MKF in Slovakia, the classification of function, and this questionnaire is intended for parents. Next slide, please. On this slide, I would like to say that the outcomes of this method these are numeric outcomes. We can use them very well, still with the awareness that it's still just figures. We can compare these figures, we can apply statistical analysis because we use electronic versions of standardized questionnaires. Those outcomes like the rate of filling in of the items function profiles in the course of time and other data allow for statistical analysis for individual and population levels, but still these are just numerical data. How can these numerical data contribute directly to improvement of early childhood development care of every child? What are the actual consequences? Interpretation decides this. Interpretation of these numerical findings is decisive. And this is a very important role of the pediatrician, how they will work further, how they will use what they obtained through this standardized tool, how they will apply the outcome in communication with a parent, with a child. And the standard procedure that I mentioned at the beginning also suggests these procedures, how to make recommendations, what to do in follow-up. Just for information, the database at the end of 2023 contained data from more than 240,000 questionnaires and some 6,000 parents filled in monthly. Registrations in online form of monitoring where 28% of primary pediatricians. How many doctors use the paper-based version? We do not have such information. Next slide, please. This is rather for illustration because I would like to say, I would like to continue. We need to interpret the results and use them further. Healthcare and monitoring of healthcare development in our country is getting momentum. But there is already the first document in place that was created by the intersectoral working group at the Ministry of Social Affairs that includes that also includes primary pediatricians in taking care of young children. I would like to stress this. If we are based on the fact that developmental function is one continuum from age-appropriate expressions through imbalances, delays, up to disability, it is necessary for healthcare and monitoring of children in this early age. We need to link this to early intervention, and we need to perceive all the system as inclusive, multi-sectoral system of taking care of early childhood development. In Slovakia, we have a special situation because up to the age of 3, more than 90% of children are at home, are taken care of at home because there is a parental contribution taken by the parents up to the age of 3 years of the child. And the insurees of our biggest health insurance company, there is 100% of patients come for regular medical checkups. So the care for early childhood development in our country is really very high level, and it's crucial. I would like to ask for the next slide.
And Olga, I will have to ask you to try to wrap up. We have much over time.
Okay. Je to vlastně poslední slide.
This is my last slide, and it shows how long it took to develop this method and this web portal, how long it was in development, thanks to UNICEF, what we managed, and also what we are planning for the future. So this is my ending. This is for conclusion, and let's hope with our mutual effort we can start and kick off something that every parent with a small child needs, the right support in order for the children to reach its full development potential. Thank you very much for your attention.
Thanks a lot, Olga. And this was also another amazing example of what can be done in a country. Thank you, Olga, for reiterating that the tool is only really a tool to help interaction between a child parent and a pediatrician and a doctor, and in this continuum of developmental monitoring in which relationship, trust, and care are the key ingredients. We have come to the end of our webinar, and we have more than 500 participants still who have stayed to the end despite delays, and we are sorry for the delay, and thank you so much for your interest and attention. And we have one more speaker to close this webinar, and it is Dr. Gabriele Fontana from UNICEF Health Advisor for UNICEF Regional Office for Europe and Central Asia. And I kindly ask him to share the last remarks, the concluding remarks. Gabriele, if you are here. And just
I am here. I hope you can see me. I see the camera is what it is.
Excellent.
Okay.
Please go ahead.
Colleagues, we're way over time. I would not call myself a speaker. I just have the pleasure to bring this meeting to a closure. And I will be very, very brief since we're way beyond time. I'm very impressed with the increasing participation and diversity of colleagues joining us in these webinars. By the way, today we had over 600 people connected from all over the region, from Portugal to Kazakhstan and beyond, including India, Kenya, South Africa. I saw even colleagues from Ukraine and Palestine who are always in our hearts these days. What I appreciated the most from today's webinar is that we went beyond advocating for early childhood development for children. We are looking at how to make it happen in health systems. Stating how important it is to embed developmental monitoring in routine pediatric services is relevant, but does not get the job done. But understanding how some countries have managed to improve on developmental monitoring through health systems can help us to identify good success factors, good strategies and tools that we can adapt to our country context and replicate their success. Today we heard how we need to have the right policies in place, we leverage the necessary financial resources, we need to sensitize and educate health professionals, capture ECD activities in information system, find some efficiency strategies in some cases to achieve more with what is available, reprioritize resources. Beyond the technical competencies, all this requires engagement with policymakers, health professionals, parents, and groups of interest. And I think we have learned a lot today. I'm not going to summarize it. I want just to thank our colleagues in WHO and UNICEF who make this event possible, the translators who allow us to communicate effectively, and all the speakers, Revan and the colleagues from Scotland, Portugal, Azerbaijan, Slovakia, who share their insight and suggestions. I hope we leave this call not only with renewed enthusiasm, but also with some concrete elements and tools that can help us to reflect on how to strengthen developmental monitoring in each one of our countries. Let me conclude here, wishing us success in our efforts for early childhood development and looking forward to see you all at the next webinar.
Thanks a lot, Gabriele, for keeping it sweet and short and still up to the point. Thank you amazingly to all the presenters. Please scan the code, subscribe to the Health Systems for Early Child Development mailing list so that you can get all the resources and all the links that have been generously shared through this webinar. And as Gabriele said, looking forward to see you. The next webinar will be on the 12th of March and dedicated to early childhood intervention, an important step that we mentioned many times today that comes after developmental monitoring and after concerns have been observed. Looking forward to your participation and stay well.